Vascular liver diseases, portosystemic shunt in dogs and cats, and hepatic encephalopathy. Vascular liver diseases are number 1, portosystemic shunt, also known as PSS, number 2, vena porta hypoplasia, and number 3, hepatic arteriovenosus fistula, also known as AVF. Portosystemic shunt is a vascular connection between the portal and systemic venous system. It can be congenital or acquired. In congenital portosystemic shunt, it can be intrahepatic or extrahepatic. And acquired portosystemic shunt is a response to backwards portal hypertension. In venae portae hypoplasia, it can be primary or secondary. In primary, it is hepatic microvascular dysplasia, also known as HMD. There is no portal hypertension. In secondary vena portae hypoplasia, it is a result of portal vein occlusion. In hepatic arteriovenosus fistula, this is a communication between the hepatic artery and the portal vein, as portal hypertension. It's also known as the arterioportal fistula. In hepatic encephalopathy, this is a metabolic dysfunction of the brain due to a liver dysfunction. It is a syndrome, not a disease. The acute is extremely rare, and the chronic form is present in 95% of cases. In chronic portosystemic shunt hepatic encephalopathy, it can be caused by protein-rich meals, and there's grades 1 to 4. There's no correlation between the amount of NH3 and the severity of the disease. Thus, the lab diagnostics findings of portosystemic shunt hepatic encephalopathy. The treatment of acute hepatic encephalopathy are: number 1, treat the seizures. Give levotiracetam and do not give diazepam. Number 2 is fluid therapy, and number 3 is decrease the absorption of NH3. And number 4 is diet. In regard to NH3, the protein should be well digestible in small amounts and given frequently. The vascular diseases are portosystemic shunt, vena porta hypoplasia, and hepatic arteriovenosum fistula. Portosystemic shunt is an abnormal vascular connection between the portal vein and the systemic venous system. It allows the portal blood to reach a systemic circulation without passing through the liver. Therefore, the blood is not detoxified. It can cause destruction of the neurotransmitting processes of the brain and lead to CNS problems. Consequences are increased toxins in the systemic circulation, such as NH3, and liver atrophy. The liver does not become developed due to decreased hepatic blood flow. So in congenital portosystemic shunt, it can be intrahepatic or extrahepatic. It is due to an abnormal embryonic blood vessel found in young animals, and it has portal hypotension, not hypertension, so there's no ascites. In intrahepatic portosystemic shunt, there is a persistent embryonic ductus venus. The ductus venus is a fetal connection between the umbilical vein and the vena cava caudalis. It normally closes in 3 days, normally after day 15 to day 18. It is found in large breed dogs, such as Irish wolfhounds and golden retrievers. In extrahepatic portosystemic shunt, there's an anatomically abnormal communication between the portal system. For example, in portocaval, this is one between the portal vein and the vena cava. Found in small dogs and toy breeds, such as Yorkshire Terriers, Dachshunds, and Pugs. Portosystemic shunt can affect 3 organ systems: the neurological system, the alimentary canal, and the urinary system. In the neurological system, it can cause tremors and salivation and head pressing. In the alimentary canal, it can cause vomiting and diarrhea. And in the urinary system, it can cause polyuria and polydipsia. In diagnosing portosystemic shunt, we mostly look at the physical signs, which are mostly neurological, and we can look at the blood work as well, where we can see leukocytosis and hyperproteinemia. And we can use ultrasound to detect whether the shunt is intrahepatic or extrahepatic. In acquired portosystemic shunt, this is a protective response to portal hypertension. It happens when the vena porta is not able to penetrate into the liver due to increased resistance due to cirrhosis or chronic hepatitis or a tumor. This leads to backwards portal hypertension. There are 3 main consequences of portal hypertension. The first one is ascites. The second one is acquired portosystemic shunt. And the third one are gastrointestinal signs, such as edema and hemorrhages. The surgery for extrahepatic portosystemic shunt, so it's to partially narrow the shunt. You put a ligature around the shunt that doesn't completely close the lumen. Or you can do an occlusion closure, which is putting a ring around the shunt that it will close gradually over weeks, allowing the portal system to get used to the increased hydrostatic pressure. Basically, put a metal ring around the shunt and it can lead to a complete closure of the shunt over weeks. The next disease is vena portae hypoplasia. The primary forms are hepatic microvascular dysplasia, also known as HMD, and the secondary forms are vena porta occlusions. So in hepatic microvascular dysplasia, there is no portal hypertension. The disease consists of a congenital hypoplasia of the vena portae. It cannot be seen on ultrasound since it is not a macroscopic shunt. It can be found congenitally in Yorkshire Terriers. The disease can exist alone, so you can have hepatic microvascular dysplasia by itself, or with congenital portosystemic shunt. The treatment is with the diet. The next disease is hepatic arteriovenosus fistula. It's a communication between the hepatic artery and the portal vein. So blood flows towards the portal vein. This leads to portal hypertension and it can cause ascites and acquired portosystemic shunt and gastrointestinal edema. It is a congenital disease, and on the ultrasound we can see a large descended pulsating vessel. The treatment is to do a lobectomy and to treat the portal hypertension. The final condition we're looking at is hepatic encephalopathy. It is a syndrome, not a disease. It's a metabolic dysfunction of the brain due to liver dysfunction. Acute hepatic encephalopathy, it's extremely rare. It's caused by toxins, infections, and drugs. It leads to acute liver failure. It can cause severe brain edema and cause seizures and comas. Chronic hepatic encephalopathy is much more common. It's around 95% of cases. It can be found in portosystemic shunt due to decreased liver function. In cats, it can be found when they have anorexia, which leads to decreased arginine, which causes hepatic lipidosis, which can increase the amount of NH3, which damages the neurotransmitter systems. In congenital portosystemic shunt hepatic encephalopathy, the clinical signs are connected to how much protein-rich meals they have. It comes in episodes, so the intensity of the clinical signs can increase and decrease. However, there is no correlation between the amount of NH3 concentration and the severity of the signs. 90% of patients have neurological signs, and 60% of patients have gastrointestinal signs, such as anorexia, weight loss, vomiting, and diarrhea. If it is caused by acquired portosystemic shunt, there are pronounced gastrointestinal signs due to the portal hypertension, so we can see ascites, edema, and melena. There are also urinary signs, so we can see polyuria, polydipsia, urolithiasis, and dysuria and hematuria. And the neurological signs, which are the main ones, are behavioral changes, apathy, lethargy, depression, circling, head pressing, and sleepiness, and seizures. The seizures are quite serious. For hepatic encephalopathy, there is a grade 1 to 4 system for the clinical signs. So grade 1 is lethargy, depression, and personality changes. Grade 2 is ataxia and circling and head pressing. Grade 3 is severe salivation and seizures. And grade 4 is comatosis, and they're non-responsive. So the factors that can cause hepatic encephalopathy are protein-rich meals, gastrointestinal bleeding, and constipation. So if the feces are in the colon for a very long time, more toxins can be absorbed, which can cause hepatic encephalopathy. Azotemia and dehydration as well. Also, hypokalemia and alkalosis is very dangerous. So for the lab diagnostics of portosystemic shunt or hepatic encephalopathy, we can see elevated liver enzymes such as ALKP, ALT, and AST. They're much higher than normal. We can often see a failure of liver function without necrosis. And for the urine, we can see alkaline pH. When doing an ultrasound, we can see a smaller liver and enlarged kidneys. When treating acute hepatic encephalopathy, First, you need to treat the seizures. Give levetiracetam and do not give diazepam, as it can cause liver problems. Then stabilize the patient by giving fluid therapy and an acid-base infusion, and decrease the absorption of NH3. So decrease the toxin production from the intestines. Do a rectal enema and then give therapeutic lactulose. Lactulose is a non-absorbable disaccharide, and it is fermented by the colon bacteria. It's able to increase the amount of NH4, which is impermeable, and it traps NH4. And the fourth solution to treating hepatic encephalopathy is to address the amount of NH3 in the diet. So we do not want large amounts of digestible protein making it into the colon. So feed a normal amount of protein, but make sure it's well digestible, and give it in small amounts and make sure you give it frequently. If you give too much protein, you'll cause hepatic encephalopathy. But if you give too little protein, you can cause a negative energy balance, which can lead to catabolism.